All right, everyone, we're just going to get started, especially because um, we've got housekeeping stuff. Make sure that you put your name, phone number, and email, and which association you are with in the chat, because that records it for us so we can print that out for later. I have the registration printed and I'm checking everyone off, but there's actually quite a few people, so I don't want to miss anybody in that. Um, let's see. Also, make sure that you mute yourself just so that we don't interrupt Lisa in her presentation. And if you have any questions, we'll be monitoring the chat so we can take questions and answer them at the end for question and answer time. All right, let's see here. Let me introduce our speaker, Lisa. So today we have Dr. Lisa Campbell. I am super excited that she's offering a presentation on just a little bit different spin than what we typically see. I had reached out to her at the middle of the year or at the beginning of the year and asked if she would be interested in giving us a presentation on improving the
I think she's
quality
over the whole
of
planet.
patient
She's not a scary dog. She's not.
of the patient experience, because we're all feeling it. I know in my health system, that's like one of the top discussion points in every meeting, it seems like. And she is sharing what her experience is and doing that. She's a national healthcare educator. She has her own podcast. And I just want to say welcome, Lisa Campbell. There you are.
Thank you so much, Carolyn, and thank you everyone for signing up for this session. I'm honored that this is the highest registration that you have. I was like, whoa, everybody's coming to see little old me. So let me just begin by saying thank you to all of you for the work that you do on a day-to-day basis. I've had the privilege of working in healthcare since 1992, and I remember the very moment when I decided I was going to be in healthcare. So I wanted to be a lawyer, but I also wanted to be in healthcare. And I remember seeing my aunt, who was also my godmother, with these big, gigantic nursing books. This was before ebooks. This was in the 70s. And I remember the big, gigantic books, her transition from LPN to RN. And I just was amazed at the work that she did on a day-to-day basis. And so I am thankful to her for those big books. However, after starting in healthcare as a medical assistant, I realized very quickly that I did not want to be a nurse. It was something about being in an exam room, interacting with the patient, asking them for their medications, because I had called them the day before to say, please bring your medications or a list. And repeatedly, it wasn't happening. And I just came to the realization after working in the clinic, working on the floor, I was not made for the clinical side of healthcare. I needed to pivot to operations, and that's exactly what I did. This presentation today is titled Beyond Registration. For those of you who don't know, patient access, their old school name is patient registration. And I was reflecting this morning, thinking about working on the floor at University of Chicago hospitals in the 90s. And we had unit secretaries who were on the floor assisting with orders and just all kind of things. And so I'm just reminded that the folks who are at the front line are so much more than check-ins and paperwork. When we talk about the clinic setting, emergency room setting, it's the first contact that our patient has with our healthcare facility. They essentially set the tone for that patient encounter. That process that they carry out is the unsung foundation of the patient experience. And the way we treat our patient access colleagues directly impacts how our patients experience our care. Throughout this presentation, I'm going to infuse lots of experience. I have had the pleasure of working with everybody in healthcare from the back of the house to the end of the house, right? So if you don't know, healthcare has like a front, a middle, and a back. I've had an opportunity to work with everyone. So this webinar isn't about technical training. This is about a cultural transformation. It's about reshaping the way we work with those who are often treated as less than because they don't wear scrubs, they don't have a RN, MD behind their name. And so we want to challenge that perspective together starting right now. So I have a very small slide deck today because I don't believe in a long presentation with a bunch of slides. So we're going to start off by watching a 5-minute video interaction between a patient access specialist and a patient. And it's very short. I happen to be representing the patient access specialist in this video. So let's check this video out. And it takes a couple of seconds for it to load up, but it'll be there now.
Next patient, please. Good morning. Good morning. I have a 10 o'clock appointment, Dr. Lewis. Yes. May I have your ID and insurance card, please? Okay. I'm just going to make a copy of both of these. One moment, please. Excuse me, I already uploaded my insurance card last night to your system. Yes, but I have to make a copy for our in-office files, and then I'll make sure that both of them are uploaded to your electronic health record. Okay. Thank you. Thank you for being a good patient. Okay, no problem. Okay, I'll give both of these back to you. And according to our insurance printout, you have a deductible that you will have to pay today before you are able to see the physician. I've never paid a deductible before. Can you please check to make sure you got the right name? Yes, yes. So when you uploaded your insurance last night, we actually ran it through our system, and then you actually acknowledged that you understood our policies, our policies that are actually on the wall. And basically, our policy states that we collect the money up front before you see the provider, and then we bill the insurance company, and that's how our policy works. You know what? I do not remember. I uploaded the information. I did not read what was there. Was there any way you could bill me and I'll pay it later? Because I really would like to see the doctor today, and I don't have my charge card with me. I'm sorry, ma'am. Our policy, the one that you signed last night, and it's also on the wall here, states that you must pay prior to seeing the physician. That seems kind of. And how much is my copay? So it's actually your deductible, and it's $500. $500? Yes. So it's actually on your insurance card here. Yes. So you see, you have a $500 deductible. Oh, I never noticed that before. But I can go home and get my charge card. You take charge cards? We do, but you have to pay before you see the doctor.
You know what? Can I speak to a supervisor?
So you can, but the supervisor is not going to tell you anything different than what I'm telling you because our policy states. So the policy here,
Yes.
as well as the policy that you signed last night when you signed in for your appointment, you agreed that you would pay the dollar amount up front prior to your appointment.
You know, that's quite a bit of money to come up with, and I haven't even seen a doctor yet. You should. Can I speak to a supervisor?
But the supervisor is going to tell you the same exact thing.
Wow, that's kind of ridiculous. But I may have to reschedule, and I really hate to reschedule.
I'm sorry, ma'am.
I may have to. You know what? I hate to go on Google and give my opinion of your facility here, because this doesn't seem right. That I have to pay before I can see the doctor. You can't bill me later. Does that make sense to you that you can't bill me later?
Well, ma'am, do you visit the dentist?
Yes, I do.
They have the same policy, so we are using the same policy that the dentist use.
Okay then. Well, I'm gonna have to reschedule. Can you give me another?
Yes, ma'am. So how about 2 weeks from today?
That's fine.
Okay. All right.
So before I come back, I have to bring $500.
Yes, ma'am.
Okay then. I mean that's your policy. That's kind of ridiculous, but I guess there's nothing I can do about it.
Okay, ma'am. Thank you for understanding.
Okay.
All right. Have a good day.
Can I have my card, please?
Yes.
Okay. Thank you very much.
Thank you. Bye-bye. Next.
So, funny story about that video is that is another aunt of mine. She's not a nurse, but she and I were in the office, and this is just funny. When Carolyn reached out to me, I was like, this was early this year. I can use this video. I recorded that video 3 years ago. And my aunt and I were in my office. We were having a conversation about patient experience and how she felt she was treated at the front desk. So we didn't have a script. We literally were just having that conversation. And she told me that she felt I was nicer to her than what she experienced in the past. So I have a question for you all. What stood out, and you can type in the chat, what stood out for you? What did you see go well? What felt awkward, strained? How often do you think this happens in your facility? Now, that encounter kind of portrayed a clinic setting, but some hospitals, health systems are collecting payments up front because the thought process is, and it has been for a very long time, that it is easier to collect money from the patient when they're most vulnerable, when they need to receive care, as opposed to spending resources on the back end collecting money that we won't receive. And when I talk to a lot of people about this concept of collecting that money up front, most of them will say, oh, it's not fair. Hospitals have so much money. But if you are a leader and you've had an opportunity to look at the budget, you will learn that our largest expense in healthcare, our salary and benefits. And if we don't bring in enough money to pay the bills, we can't stay open. So I see in the chat, several of you are mentioning that the PAS team member didn't utilize her heart first and empathize. And notice, even though she didn't look like it, that lady in the video, my aunt, she just turned 80 last week. So she looks relatively young, but she's truly a senior. Also in the chat, I'm seeing this happens a lot. It seems like they're more worried about money than taking care of the patient. That's that ongoing, I would say, tug of war that we experience in healthcare. Surprise about not being able to speak to the supervisor, right? Blaming the patient for not understanding. I personally, outside of this presentation, and thank you all for your comments, I really think that we need to do a better job as a healthcare ecosystem of educating our patients in the community outside of the visits, because let's just be honest, patients don't understand the business side of medicine, deductible versus copay. They just know they have insurance, and for the most part, that's all that they know. So let's move on to our next topic. And let's be honest, change is hard. We survived that pandemic, but change is hard, especially on those who have little control over the changes that they are being asked to implement. Most patient access specialists earn about $15, $16 an hour. Many of them have a high school diploma. Some may have an associate's degree because they got that job, because maybe they went to school for medical records or medical billing and coding. So they get this job in hopes of growing within the healthcare system. And so they take that program or take that job as a point of entry. But many of them are also single parents, caregivers. Some are working more than one job. And when I was pulling together this presentation, I started to think about in the 90s when I worked in the clinic during the day as a medical assistant in a multi-specialty clinic. And then at night, I would do a few hours on the floor, on a surgical floor. I was a single parent of a special needs child, and I could not make ends meet. So I had to juggle all of, working during the day and working at night. And so for these folks, this job is stressful outside of the interactions that they have with non-patient partners. So, things are happening in healthcare very fast. Policies are shifting, insurance complexities, and oftentimes patient access specialists work under some unrealistic expectations. I've watched organizations implement major policy changes without bringing the actual patient access staff to the table. They will bring, the manager, but the manager is not typically the one that's doing the day-to-day work. And so without consulting the people who are actually doing the clicking and the checking, and as nurses, if you get a new electronic health record system and nurses aren't at the table, we go live and then we look at these templates and we're like, this makes no sense, right? But they've spent money to build the system, and that's what we have. So not checking with those folks, bringing them into the conversation is a recipe for resistance. Not because they don't care, but they're just simply overwhelmed. So last year, I had an opportunity to do a project, which it was a specialty that I had never done before, but I was partnered with a nurse. So I happen to like nurses. I have a whole family I'm the only non-nurse in the family. It's hilarious. But I said, we can open up a nursing home and I'll just handle the administrative part. So anyway, the nurse and I were on this project for optimizing the revenue cycle for trauma activation services. So just to set the stage, there were 11 hospitals, some trauma level 1, 2, 3, 4, right? And we were involved with every person who touched the patient's record. Notice I didn't say touch the patient, touch the patient's record, touch the patient's account. All these folks, there were like over 100 people. And we were brought in because the hospital system was losing money because trauma activation services were not captured properly from the beginning, and it just filtered on downstream. And so when I say trauma activations, I'm talking about the patient who comes in via ambulance, or the patient who's the parent is at a sporting event, the parent picks up the baby and brings them to the hospital, right? But nonetheless, trauma. And so we were brought in, as I call us, the admin clinical duo, to help them look at systems, start to work together so that they can improve their revenue cycle. What was really interesting when we started having meetings with this group, many of them had no clue who the other folks were that touched the patient from start to finish. They didn't really understand what role that person played. And I left that project really confident that they had a greater respect for each other as a result of that project. What was really interesting about that project, they had a cyber attack, and so the project kind of stopped for a couple of weeks. But even in the midst of that, the relationships that we helped them create, I believe, impacted their culture. So if you think about the work that you do, when was the last time you were told, just do it? No explanation, just do it, right? Type in the chat. How did it make you feel? Empowered, respected, or overlooked, right? I like to say we were voluntold to do something. As a nurse, as leaders, our job is to learn how to bring those patient access team members into the conversation and not just push changes on them without context. So speaking of that 11 hospitals we visited, one of the things that I noticed was that the culture of the level 1 and level 2 trauma facilities was totally different than the level 3 and 4, right? So the level 4, I live in Chicago or outside of Chicago, so I'm used to the big hospitals. Some of the level 4 hospitals had 2 ER rooms, right? Everybody had more than one job, but interestingly, they seem to work better than the larger hospitals where everything was disjointed. And so, as a person who has worked with clinics, hospitals, outpatient centers, surgery clinics, insurance companies, the government, I can tell you this with certainty. Patient access are not just support staff. They are culture carriers. What do I mean? That first interaction that they have with the patient helps begin the perception of our patients, of our health systems, good, bad, and indifferent. So for I would call it the meat and potatoes of this presentation, I really want to introduce you to this framework that I created. But before I do that, I want to tell you this story. So in one of the trauma hospitals, a patient access specialist said to us, we weren't told, or we don't have the authority to select during the registration process that this patient is a trauma patient versus just a plain old emergency room visit. And so I said, what do you mean? They said, our boss told us for every visit, it is always emergency. And so the managers even went as far as saying they don't even have that option. So now one of the things that the nurse and I did as a part of this process, those of you who are Lean Six Sigma enthusiasts, we went to the Gemba, we went to where the work was being done, and we just simply asked folks, when you register a patient and you click here, what options are there? And could you click trauma? And the PAS specialist was like, yeah, we can click it, but we were told not to click it. And I remember not on that project, but a different project that a patient access specialist caught an error that could have resulted in a six-figure loss. That's how huge this error was. But her attention to detail protected the hospital, the physician, and the patient. This is the kind of value that we overlook when we reduce people to their job titles. So I have another question for you, and thank you for participating in the chat again. What do your patient access team members do to protect you every day that you don't even really think about, but they actually just do it? And I know some of you probably have worked in emergency rooms. Emergency rooms have gotten a little interesting today. We have some improvements like with provider and triage, which I think is the best thing ever. But in some settings, there isn't even conversation between patient access and the provider in triage, and they are literally sitting elbow to elbow with each other. So we have to change that narrative. So I'm going to move into the framework because we have 30 minutes left. And to help us reimagine how we can support and partner with patient access, I developed this access framework. Each of these six principles isn't just a theory, it's a habit, it's a leadership habit. It's about how we go from working around patient access to working with them. This is how we build shared accountability, how we elevate morale, and then create this team culture where no one is dismissed because of their position. Now, think about it. What if you are an emergency room nurse and leadership made the decision, no more patient access specialists. Nurses, you will register patient, you will triage the patient, you will get the patient to the back to another nurse who will care for the patient, and that's it. How would you feel if that happened? So with this framework, I believe it is important that we start to do some self-reflection on what we've done to contribute to this culture or lack thereof and how we can move forward. So the first part of this framework is acknowledgement. Acknowledgement is so very important because if people don't feel seen, they won't stay engaged. Let me say it again. If people don't feel seen, they won't remain engaged. Patient access specialists are often ignored until something goes wrong. They are expected to maintain accuracy. They're expected to be composed, to be professional under pressure, often while being ignored and interrupted and blamed. And yet, believe it or not, they are responsible for the foundational elements of patient care. And depending on the setting, they're responsible for ensuring patient identity, making sure we have the right patient, patient insurance eligibility, coordination, communication. There's a lot of things that they do that often goes unnoticed. As nurses, as quality improvement professionals, you have immense credibility within your organization. Your words carry weight. Now, I do know there are some exceptions where the political maze is very difficult to navigate. This is the reason why I do not work at any organization because I'm just not good with politics. I've always believed in being a part of the solution and not a part of the day-to-day minutia that goes on. When you speak well of someone on the patient access team, other people notice. When you take 10 seconds to say, "Ooh, thank you for managing that check-in line during that rush on Monday. You know how busy it is." You are reinforcing to that person a culture that you see them. So some ways to, and there's a whole list, but we only have 60 minutes. Um, Ways to acknowledge patient access staff. A quick compliment during a shift. A handwritten notice. I didn't realize how much a handwritten notice, how far it went. One of the PAS at that one of those hospitals I was at, I just wrote them a note and I just simply said, now I'm not an employee. I was just a consultant, right? Or not just a consultant, but I was a consultant. I was someone that wasn't a permanent fixture. But I just said, "I see you. I appreciate you. Thank you." She sent me an email and was like, "Thank you so much." That made her day. She was literally ready to just walk off her shift because she was just overwhelmed. And, in those trauma one hospitals, they were humping. And so it wasn't like they had some periods where the volume was low, but most of the time people were coming in and out. Other things you can do. If you have a department huddle, include their wins. If you have a newsletter, include their wins, okay? I see someone typed into the chat, they are actually the heroes making sure the right information is entered. Yes, because there's that old saying, which is still relevant today: garbage in, garbage out. That information flows from the front of the house to the middle of the house to the back of the house. Think about in a role as case management. If you got the incorrect information regarding the patient, that may delay how that patient's care is managed. So the second letter of this access framework is about creating psychological safety. Psychological safety is not about being comfortable all the time, because we're not comfortable all the time, but it's about feeling safe enough to be honest. And in fast-paced healthcare environments, honesty saves lives and protects careers. Most patient access specialists have shared with me they don't feel safe asking questions or offering feedback, especially in high acuity areas. Why? They fear judgment. They worry that they'll just be seen as patient registration if they admit they're unsure about something. That fear creates silence. Silence can lead to incorrect data, missed trauma indicators, errors in the types of bill that affect compliance and revenue. Many of you know some people say we are moving. I feel like we have moved to this pay for performance, value-based care. So every little thing we do matters in the big grand scheme of things. As nurses, your tone matters. When you say, "Thanks for checking," instead of, "You should have already known that," you're creating a space where learning is possible. And I just had a flashback. So back in 1997, I was working at University of Chicago Hospital. I was brought in as a patient care technician to work the floor, someone who already had, experience in drawing blood and vital signs and EKGs and all of that. And they said, or the human resource department said, "Okay, in order to keep your job, you need to pass this training." Well, this training, and watch this, nurses, I know you're going to be like, "What?" This training consisted of starting IVs. We had to be able to read EKG strips, right? Now, clearly, I wasn't a nurse. So imagine me, 1997, I'm 52 today, so you can tell how old I was in 1997. And the nurse trainer who was doing our training was going over the different, rhythms, Mobus type 2 and all the things. And I was sitting in that room thinking, I'm not going to make it. And I asked her, what can I do to learn the differences in the rhythms? We had the little, what do you call them, calipers, and we were doing this to figure out if it was VTAC and all the things. And she was like, you just need to use the information that I gave you. Now, one thing about me, no is not an acceptable answer for me. I called up my aunt Lynette and I said, I need to learn how to read all of these rhythm strips by Monday. I went to her house on Saturday. I did not leave until sometime on Sunday. But trust me, I came in that room confident and did better than everybody else because I had a secret weapon in my community outside of work. Everybody didn't have that. And some of my coworkers didn't pass that portion of the test and didn't keep their job. And so it's so important that we create a space where learning is possible as opposed to impossible. All right, the next letter C is about cultivating an ownership mindset. Ownership transforms a task into a mission. As someone who has worked closely with everybody, I have worked with physicians, nurse practitioners, physician assistants, the lab, billing, coding, medical records, pastoral care, you name it. I can tell you that when people take ownership, the entire organization benefits. But here's the thing. Ownership doesn't happen automatically. It's cultivated when people understand the why behind their work. They're trusted to make improvements. They're supported when they step into leadership moments. One of the reasons that I transitioned from the work that I was doing in healthcare, from billing, coding, compliance. I was even doing clinical documentation improvement. I shifted from that work 3 years ago into the role of coach, motivational speaker, because I felt that our healthcare system was so fragmented, it's so broken, and it breaks down daily that I wanted to be a person who wasn't necessarily currently doing the job, but definitely understands the inner workings of the healthcare system. And so your role as nurses, social workers, I saw there were some social workers here. Invite patient access specialists to share their ideas. When they recommend a change, be a learner, not a judger. Respond with curiosity, not defensiveness. Next letter is engage. So I've worked with a lot of healthcare teams, and I was reflecting on this. I've spent more time working out of Illinois than I've worked in Illinois. And that was actually by design. One day I was auditing a clinic here in Chicago, and I happened to open up a record to audit it for a person that I knew from high school, a person who was very promiscuous. I audited that record in seconds because I was like, I cannot unsee this. And so I I decided I cannot work in Illinois anymore. I need to be outside of this entire state. But I've worked with so many teams, and I have witnessed that the most respected leaders don't command respect. They earn it through consistency, clarity, empathy. Influence is not about title, it's about tone. A few years ago, a few medical coders told me, the physicians listen to you because you have PhD behind your name. And I said, that has nothing to do with it. It's about my tone. It's about my level of emotional intelligence. I don't go and meet with a physician and threaten them with an orange jumpsuit, right? When I'm trying to get them to improve their documentation. I go in as a person who wants to partner with them for the greater good of the organization. Nurses have the power to influence culture through how you speak to staff. And if you're not a nurse, anybody, how you speak to non-clinical staff, how you respond to stress. Now, when that ER is jumping, we have some tense moments. But when those tense moments slow down, go back, be big, put your big girl underwear or big guy underwear and say, hey, I'm sorry I yelled at you. I'll never forget, and don't judge me. I was working at Mercy Hospital here in Chicago. I was fresh out of medical assisting school. I was in the ER and I went to draw some blood and the labs came back and the patient's electrolytes were all out of whack. Well, it turns out that I drew the blood from where the IV was, and so that resulted in those test results. I'll never forget that physician pulling me to the side and educating me on why what I did caused an error. I did not feel ashamed. I appreciated that he was willing to help me learn so that I could be a better partner to him, right? Because now the labs had to be redrawn. And so I take those moments with me because it allows me to have grace and empathy with others, even when it's bad. I remember in one ER, a nurse noticed that the patient access specialist was struggling to register a trauma patient whose family, and this was in Chicago, their family was a little frantic, a little disruptive, and the nurse stepped in not to take over, but to de-escalate the family, reassure the registrar, and then help walk the patient family through the rest of the process. That moment didn't just solve a crisis, it built credibility and trust around the team. Another fun fact I will tell you about me, I don't know, probably about, and I hope that this will help you, probably about 5 years ago, I realized that I spent too much time reading healthcare journals. And I felt lost. I felt burnt out. I felt a little depression coming in. And so I started to go back to my first love, which was reading. And I started reading any leadership, self-help book that I could find. When I tell you it changed my mind forever, it allows me to stand in front of you and drop these different perspectives and gems to you today with enthusiasm and peace and no weight on my shoulders that I'm taking to bed every night. And when I looked at myself in that video and I look at myself today, I look much happier. My face is slimmer because I started to get rid of that weight that was literally weighing me down and making me feel stuck. Some of you, I know, before you go to your jobs, before you log on to Teams, you cry because you don't know if you're going to be able to make it another day. You have to figure out what you can do to get back to you, because as they say, you cannot pour from an empty cup. And I wake up every day with my cup full so that I can pour in to others. All right. Letter S, simplify quality improvement. I have reviewed thousands, I would say millions, but I didn't really keep track. So I'll just say thousands of audit findings, trauma most recently, outpatient, emergency documentation. And you know what I see often? Good people making avoidable mistakes because the systems around them are too complicated. Patient access specialists are asked to juggle a lot of things. Walk-in complaints, updates with providers, just all these things to keep the line moving. And so I think we need to get back to simplifying how we attack quality improvement. So if it's quality improvement with your patient access specialist, just pick one thing, one measurable goal that you're going to attack. I'm reading this book right now that talks about scaling your business, because that's something that, I'm doing. And one of the things the author talked about was, instead of having just the old school SMART goals, what if you had a goal that seemed impossible? That's like a challenge. It is, you think it's impossible, but when you put your resources towards that, you can achieve that goal. So one measurable goal, make it visible on a board, on a tracker, in a huddle. Now, I know those of you who may still be working part-time in the ED, that board it's a lot. I walked past it and was like, whoa. But make it so that you can see it. My vision board is across the hall on the wall. Every time I come downstairs to come to my desk, to leave the house to go to water aerobics in the morning, I see that goal and I'm motivated even more to accomplish it. But the other thing is, celebrate the small wins out loud. Sometimes you don't know how much a little small win goes a long way. So what's one piece of registration process do you think could be simplified with your help? Drop that in the chat. And thank you guys for being here today. I see there's 47 of you here with me live. Thank you for participating in the chats. I know sometimes webinars can be hard, which is why I like to be on camera, standing up, just because I want to give you the feel like we're at a face-to-face conference, but we're not. We're all at our respective computers. So while you're thinking about that, I am going to transition to the last S, which is about sustaining change. Starting strong, that's easy, but staying consistent, that's where the magic happens. That's where culture is either built or it's broken. In my work with many hospitals, I've seen teams launch amazing initiatives, improve trauma documentation, check-in efficiencies. But within those weeks, the wins started to fade. There was no follow-through. And so they were back to where they began. Oh, I love in the chat, include PAS in the huddles. That's a perfect opportunity to celebrate, refresh. Yes, they may not understand everything that's going on, but just allowing them to have a seat in the huddle shows them that they are inside of the team and not outside of the team. To sustain change, we have to make it a part of our daily workflow. That's the difficult part. A few months ago, I made a decision that I needed to flip my day with a focus on me. Now, I can do that because I'm an entrepreneur, so I don't have to be somewhere at a certain time every day. But I decided every day at 10 o'clock, I was going to water aerobics class. It's a high intensity water aerobics class. I enjoy it. It's my time. I can close the rings on my watch, but it's something that I do for me, and it's on my calendar. My assistant, Sophia, knows. You can schedule me for something before I leave this house to go to water aerobics, but during this time, I can't do it. Unless, of course, this is my disclaimer with her. If it's a call about $1 million project, yeah, I'm all in. But other than that, I have to be consistent to sustain the change that I want. At 52, menopausal, you know, my body is doing all the things. And so I am making that change a part of my daily workflow. I'm repeating it until it becomes muscle memory, but I'm reinforcing it with recognition. I have a coach, right? Because I need to make sure that it doesn't fall off my radar so I go back to where I started. Some strategies you can use: embed the access principle in your daily rounds. Ask patient access what's working, what's not working. Create momentum trackers for consistency. I got a question for you. What's one habit you will commit to that keeps this work alive? And we're almost done, almost done. And I'm going to move to the next slide while you're thinking about that. I had a short engagement activity that you can just do, you know, individually. But I wanted to present this scenario. So I'm on this trauma activation kick. I really enjoyed trauma activation. I don't know why. It was just something about being with all those folks and, you know, talking to the trauma surgeons. It was a good time. It's a good time. So I want you to think about a situation where a trauma patient arrives via ambulance. And the patient access specialist is trying to collect the data, stay composed amid the chaos. You, as the nurse, you see the stress building. What do you do? Drop one statement in the chat. What do you do? And as you're dropping that statement, I want to talk about the value of doing that. Figuring out what you can do to help that PAS specialist in that time. This is where partnership is tested and proven. And also thinking about what can be improved to prevent this breakdown from happening. I recently purchased a book from an ER physician who talks about how unsafe it is to work in the ER, right? And that's just not for physicians, that's for everybody else that's working there as well. And as we wrap up today, I have a call to action beyond today. I want to bring this full circle back to you. You have a role in shaping culture, regardless of your title. You're in this room, so I know that your presence is felt deeply by everyone around you. And when you choose to uplift others, engage, collaborate with patient access, you create this space for dignity to grow. This access framework is not a once and done framework. It's a lifestyle. And I'm going to leave you with a quote. We'll have time for questions. Excellence is not a skill, it's an attitude. You can't always change the pace of change, policies, or the system, but you can choose how you respond. Choose to respect the people who often go unrecognized. Choose to collaborate before you criticize. Choose to lead from where you are operating. Because when you do, others rise. When patient access rises, everyone wins, including the patients. Thank you so much for letting me share this message with you today. Let's keep pushing forward for a culture that honors every role, every voice, every contribution. And let's see if we have some questions. Thank you, Carolyn, for reaching out. This was definitely meant to be.
Thank you so much for doing this. And, you know, it's true. Patient access is, they're those other people. And integrating them with the team and letting them know that they are actually a part of saving that life might actually kind of make them feel a part of that experience. So I love this. This is great. Does anybody have any questions? If not, make sure next month we have Quint Studer offering a seminar, our webinar, and the gist of his webinar is how to fill our cups. Because as quality professionals, we've got the frontline staff that is like, why are you telling me to do this? And then you've got administration telling you to do this, and we're the ones in the middle trying to make it happen. So make sure you look into that and sign up for that. We'd love to have everybody back for that. And yes, Lisa, thank you so much. You are so amazing, and we so appreciate this. It looks like everybody's checking out. So is it okay if I like summarize your slides and then send that out so people have your framework?
Yeah, I mean, you can just send them the slides.
Oh, okay.
Right, sharing is caring, right?
Yeah, no, I appreciate that. That's great. And awesome. Does anybody have anything they want to share?
Everybody has to go to another meeting.
Everybody's like, we're done, right? You give me 5 minutes to go to the bathroom before the next meeting. Yes.
Yeah.
Okay, well, we will check in for the next time, and you have a blessed day. Thank you again for coming, Lisa.
Thank you. Bye-bye.
Bye-bye.